by the red circle here. So if the aortic arch is narrowed between the brachiocephalic trunk and the left common carotid artery, then this area cannot be augmented just by a simple extended end-to-end anastomosis. So the approach has to change, and in fact, the arch needs to be approached through a median sternotomy incision, and we need a strategy to protect the central nervous system while augmenting the proximal arch. So clamping the brachiocephalic trunk and carotid arteries is not an option without the use of cardiopulmonary bypass. And then I will go through some strategies that one may use on the next slide. It is also a more complex reconstruction and takes longer to do, and therefore just simply cross-clamping the transverse arch and the descending thoracic aorta will take too long to reconstruct the aortic arch in that situation. So what strategies can we use to reconstruct the hypoplastic aortic arch? So the first strategy that we can use is to go on to bypass and then cool down to 18 degrees, arrest the circulation completely, and then having isolated the arch, open the arch and repair it. Subsequently to that, surgeons have been using selective cerebral perfusion, so a cannula or direct cannulation of the brachiocephalic trunk, and then aortic inflow into that. So the cerebral circulation is supplied, but with clamping of the descending thoracic aorta. So the bloodless field is achieved by placing cross clamps on the ascending aorta, the descending thoracic aorta, and snaring the supraaortic or head and neck vessels. The arch can then be opened and repaired, but all the time the cerebral vascular bed is being supplied by arterial inflow. The next step really and advancement is to continuously perfuse the myocardium. So instead of actually because you're able to isolate the arch without having to without having to cross clamp and cardioplege the heart, you can actually continuously perfuse the myocardium from the bypass machine such that the heart is beating throughout your arch reconstruction. This can be done at slightly warmer temperatures. So in a combination with selective antegrade cerebral perfusion, one can supply the brain and supply the heart. And then lastly, there are more and more proponents of lower body perfusion. So the diagram on the right-hand side at the bottom of the screen here shows how one may access the descending thoracic aorta just as it leaves the chest above the diaphragm through the back of the posterior pericardium. Now we can insert a cannula in here and therefore perfuse the lower body while on bypass, as well as perfusing the brain and the myocardium, and therefore just isolating the arch in order to repair the arch. This is not a technique that is widespread, but is becoming more and more prevalent. And how can we then reconstruct the arch? Well, there are options of native tissue to native tissue reconstruction. So the top diagram here shows how the descending thoracic aorta needs to be mobilized extensively and then brought up and anastomosed to the proximal transverse arch. Now this is a tissue to tissue anastomosis and should provide good growth in the long term. So that's its advantage. However, because of the extensive mobilization that's required, and pulling up of the aorta and pulling down of the transverse arch, it can actually compromise and obstruct the left main bronchus. So one needs to be careful of how much tension there is when one is mobilizing the tissues to try and afford this type of repair. The alternative is to patch augment the lesser curvature of the arch. And then the options here in terms of patches are to use pulmonary homograft or collagen scaffold patches such as Cardiacell, and more recently Cardiacell 3D, so which is a preformed curved patch. The patch is usually, as I said, applied to the lesser curvature, leaving native tissue on the greater curvature of the aortic arch, and then performing an anastomosis between the back walls of the descending thoracic aorta, the transverse arch, and then augmenting the lesser curvature with the patch. The native tissue can grow around the patch, but if one oversizes the patch, again, you can obstruct the left main bronchus or left pulmonary artery. And then lastly, interrupted aortic arch, really just an extension of a hyperplastic aortic arch repair. Interrupted aortic arch is fairly rare, about 1% of congenital heart disease, and essentially is loss of luminal continuity of the transverse arch. There are three types. Type A, where the interruption is distal to the left subclavian, and this is associated commonly with an aortopulmonary window. Type B, the commonest type, where the arch is interrupted between the left subclavian artery and the left common carotid artery, and is almost invariably associated with the VSD. And then the rarest type between the brachiocephalic trunk and the left common carotid artery, which is very unusual. In terms of management, the only way that the blood can get to the distal part of the body is through ductal perfusion, and then once the child has been stabilized, the plan would be to perform surgery to reconstruct the arch and also repair the associated lesions. The reconstruction will be done very much as I've shown you before, usually either with a direct native tissue to native tissue anastomosis, having mobilized the descending thoracic aorta extensively, or with patch augmentation. Right, so I will now move on to transposition of the great arteries, encompassing 5% of, quite common, incompatible with life without intervention, really, with a high mortality at 1 year, and defined sort of morphologically as atrial cytosolitis with AV concordance. So the atria are subtending the correct ventricles, but the ventriculo-arterial junction are discordant. So the right ventricle subtends the aorta, and the left ventricle subtends the pulmonary artery. Sort of surgical classification into three main subtypes: transposition with intact ventricular septum, the commonest type, approximately 55% of all transposition, and then transposition with ventricular septal defect, around 25% of transposition, and then more complex forms, which include obstruction to the left ventricular outflow tract and also associated with arch anomalies. And that group forms about 20% of all transposition. There is much variation in the coronary anatomy, and as you'll see from the repair, it is the coronary anatomy which is key. There are various classifications. One of them is the Yaklou classification. The other is the Leiden classification. So this is sort of a cartoon, really, showing the anatomy and the physiology. So I will move quickly on to an actual photograph taken in theatre of transposition. So this is what you see when you open the sternum. This is the right ventricle that you can see here, the aorta coming out of that, and the pulmonary artery located behind. So this is antero-posterior relationship of the great vessels, with the pulmonary artery sitting behind the aorta. You can see the coronary arteries here, left coronary artery and right coronary artery here. But as I said, there is much variation in coronary anatomy. So the pathophysiology, circulations, the systemic and the pulmonary circulations, are in parallel rather than in series, and let me just move this again. And oxygenation is dependent on mixing via a shunting between the two circulations. So this is a diagram showing that the right ventricle pumps through the aorta into the body, and then that blood is then fed back to the right ventricle, and from the lungs, the left ventricle pumps blood through the pulmonary artery to the lungs and thence back to the left ventricle. So two circuits in parallel. And the only way the blood can mix between the two is by shunting between these two circulations. So there must be some areas of mixing in these circulations. The largest area of mixing potentially is at the atrial level, then at ductal level between the two great arteries, and then finally, if there is a VSD, the smallest amount of shunting occurs at that ventricular level. So poor mixing through those shunts leads to hypoxemia, hypercarbia, and acidosis, and a very sick child. So the first step in management of transposition is to try and maintain ductal patency. So again, a prostaglandin infusion. And if the patient's saturations are still not improving with the prostaglandin infusion, the next step is to proceed to a Rashkin septostomy. So that's a balloon atrial septostomy done either at the bedside under echocardiographic guidance or in the cath lab. So once that has been performed and one has secured some mixing at atrial level, one can plan early definitive surgical repair. So that is the arterial switch operation. So I'm quickly going to go through the arterial switch operation for you now. It is an operation undertaken on cardiopulmonary bypass. The first step, once bypass has been established, is to divide the ductus arteriosus and carefully make sure that it is oversewn, such that one can then move the great vessels relative to each other. The next step is to cross clamp the aorta and then be able to, one is in a position once cardioplegia has been delivered and the heart has been arrested, to transect the aorta and then from the aorta mobilize the coronary arteries. Once they've been adequately mobilized, they can then be relocated onto the pulmonary trunk, which will then become the neo-aorta. So one then has to transect the pulmonary artery, and then the pulmonary artery branches need to be brought forward, which is called the Lecomte maneuver. Once that has been performed, the coronary arteries can be reimplanted into what used to be the pulmonary route, but will now form the neo-aortic route. Then the remainder of the aorta, or the neo-aortic route, is anastomosed to the remainder of the ascending aorta, so that we now have continuity between the left ventricle, the coronaries, and the systemic circulation. And then the final step is to reconstruct the pulmonary artery, or the neopulmonary artery, from whence the coronary buttons have been taken, and then anastomose that to the pulmonary artery bifurcation, and therefore completing the repair. The usual patch material used to reconstruct the pulmonary artery is autologous pericardium, which is taken at the beginning of the procedure. So this is, again, an operative photograph showing mobilization of the coronary arteries from the aorta. So just to orientate you, this is the inferior of the patient. You can see the bypass cannula here. This is the aortic cannula here going into the aorta there. And this is the aortic valve, which will become the neopulmonary valve, but this is the aorta emanating from the right ventricle here, and the coronary arteries that have been mobilized. They will be reflected posteriorly and relocated to the pulmonary, well, what used to be the pulmonary artery, which will become the neo-aortic root. Fine, I will now move on to truncus arteriosus, or common arterial trunk. This is a rare condition in which there is a single great vessel leaving the heart, variable origin of the pulmonary arteries from that single great vessel, and a single outlet or truncal valve, and it is almost always associated with the ventricular septal defect. Occasionally it is associated with interrupted aortic arch, and as I said, it's a rare condition. The pathophysiology is of uncontrolled pulmonary blood flow, and as the pulmonary vascular resistance drops, as it always does with age, the heart failure becomes worse as there is more and more blood flow preferentially flowing into the pulmonary circuit and therefore stealing blood from the systemic circuit. That can result in coronary steal, ischemia, and cardiac arrest. So this is important that we deal with truncus arteriosus in the neonatal period. So let's focus on the truncal valve for a few minutes. This is most commonly trileaflet in its structure, and possibly quadrileaflet, but may have anywhere between 2 and 5 leaflets. The leaflet tissue can be myxomatous, so rolled edges, thickened, and generally of poor quality, and the valve is regurgitant in approximately 50% of cases. Repairing truncus arteriosus. So the principles of repair, again, this is an operation done on cardiopulmonary bypass, and the initial step is to control the pulmonary blood flow once we're on bypass. Otherwise, there is uncontrolled blood flow to the lungs and steal from the systemic circulation. So once the pulmonary arteries have been controlled and the aorta has been cross-clamped and cardioplegia has been delivered, the pulmonary arteries are separated from the aorta, and the aorta needs to be reconstructed. The VSD will need to be closed, and this is often done through a ventricular incision, as will almost certainly the child is going to need a right ventricular to pulmonary artery conduit to restore continuity between the right ventricle and the pulmonary arteries. So repair the aorta, separate the aorta and the pulmonary arteries, reconstruct the aorta, close the VSD, and insert a conduit or some sort of connection between the right ventricle and the pulmonary arteries. In addition to this, if the truncal valve is regurgitant, this will need to be repaired. And in addition to this, if there is an interruption of the aortic arch, this will also need to be repaired. That becomes a very, very complex operation if those two further elements, or either one of those further elements, has to be performed in addition to the basic truncal repair. What are the pertinent issues with truncus arteriosus? Often these children are of small size, less than 3 kilos, and in that situation, bicaval cannulation may risk damage to the superior vena cava, and in which case the right atrium should be cannulated, but then the operation can only be done with the use of deep hypothermic circulatory arrest. The truncal valve, as I've alluded to, can be bi-tri or quadricuspid, and can be extremely difficult to repair and achieve a good result. So the advent of truncal valve regurgitation at the end of surgery, if it's sort of more than moderate, is a difficult thing to deal with. Also, how do we achieve continuity between the right ventricle and the pulmonary artery? Well, ideally, in this situation, one needs a competent pulmonary valve, but it is difficult to source small valve conduits. The smallest off-the-shelf conduit that is suitable for use is 12 millimeters in diameter, and is often quite large in these small babies. And if you do have the facility to get homografts, Small homographs, so those which are a diameter of around 6 to 8 millimeters, have a very high failure rate. So there is no perfect solution. And in fact, often we just have to make do with whatever we can to achieve RV to PA continuity. Lastly, when one is separating the aorta and the pulmonary arteries, the coronary arteries often have high and displaced origins, so one needs to be mindful of the fact that the coronary arteries can be sitting above the sinotubular junction and can be in jeopardy when one is separating the aorta and pulmonary artery. So lastly, we'll move on to hypoplastic left heart syndrome. This encompasses about 1.5% of all congenital heart disease, but 40% of neonatal cardiac death. So it is an extremely important condition to be able to deal with. It is a spectrum where in greater than one left heart structures are of inadequate size. So this can be anything from the mitral valve, the left ventricle, the left ventricular outflow tract, aortic valve, ascending aorta, and transverse arch. More than one of these is often reduced in size, such that the left ventricle is unable to adequately supply the systemic circulation. Commonly, we see aortic and or mitral atresia, or aortic atresia and mitral stenosis, or mitral stenosis and aortic atresia. The hallmark feature in these conditions is a small non-apex forming left ventricle, as I said, which is unable to support the systemic circulation. It requires an obligatory atrial septal defect to ensure that there is left to right shunting through at atrial level, to ensure there is blood that can get to the right ventricle and therefore to the systemic circulation via the ductus arteriosus. So if the atrial septum is intact at birth, this will result in significant pulmonary venous congestion and requires emergency intervention. The treatment for hypoplastic left heart syndrome overall is for a Norwood operation or hybrid procedure as a first stage of palliation, followed by a Glenn or cavopulmonary shunt, and then Fontan procedure as the next steps of single ventricle palliation. Let me just focus on the pathophysiology for a few minutes. So we've already mentioned that the left ventricle is unable to sustain adequate cardiac output, and this is either through inadequate left ventricular size or some sort of obstruction to blood flow, whether that be an atretic aortic valve or a stenotic aortic valve, or a diminutive ascending aorta or transverse arch, or indeed mitral stenosis. So the circulation is dependent on the right ventricle pumping blood through the ductus arteriosus and into the aorta, where it will supply the coronaries, retrograde, the head and neck vessels, and the splanchnic and femoral beds. So the issue is that because of the lower pulmonary vascular resistance in the lungs, the blood from the right ventricle flows preferentially into the lungs and therefore will potentially deprive the systemic circulation. So often these children will present having had an antenatal diagnosis, so we'll be aware of the fact they will be presenting with hypoplastic left heart syndrome, or less commonly, at least in the UK, is that they will present with shock when the ductus arteriosus closes and there is no longer an adequate systemic vascular supply. So the initial management is to maintain ductal patency via a prostaglandin infusion. Often the child will need volume to improve cardiac output, and potentially inotropes also to improve cardiac output. The next step really is to try and somehow restrict the pulmonary blood flow. So to try and increase, if possible, the pulmonary vascular resistance to try and reduce the amount of steel into the lungs and to encourage systemic blood flow. So we manage these children with saturations deliberately kept at around sort of 75 to 85%. So they're not given oxygen, and if necessary, they are ventilated in air and paralyzed in order to try and take control of the circulation. As I've mentioned, definitive management is 3 stages of palliation and conversion into a single ventricle circulation, the first step of which is the Norwood procedure. So this was developed by William Norwood in 1981, and the principles are to join the systemic and the pulmonary venous return to a common atrium, and that is accomplished by performing a septectomy. The right ventricle is used as the systemic ventricle, and in order to secure the outflow or the systemic outflow, the proximal pulmonary artery is connected to a reconstructed aorta. And then finally, there has to be some way of getting blood into the lungs now that the pulmonary artery and the right ventricular outflow tract are connected to the systemic circulation. And William Norwood did this using a Blalock-Taussig shunt. What are the pertinent issues? Well, again, it's about balancing the pulmonary and systemic circulation. So again, these children are run with saturations of 75 to 85% in order to increase the pulmonary vascular resistance and therefore reduce the pulmonary blood flow and maintain systemic blood flow. If with the Blalock-Taussig shunt in place and potential for low diastolic pressures, we can see coronary steal. Okay, and it's important to maintain right ventricular function. And to do this, one needs to adhere to the Starling principles. So the preload needs to be good. So there needs to be good venous return, and that means an adequate septectomy between the left and right atrium, and also competence of the tricuspid valve. There needs to be good contractility, so the coronary perfusion needs to be adequate, and also there needs to be no excessive afterload. So the outflow needs to be unobstructed, and therefore a good aortic reconstruction is paramount. So the procedure is undertaken usually at 4 to 5 days of age. The surgery is high risk with a mortality of anywhere between 10 and 20%. And after the surgery, the child will commonly return to intensive care with an open chest. This can be closed on the first or second postoperative day if all is well, and that can be delayed further according to the condition of the child. Once the chest is closed and the patient is weaned from ventilation and inotropic support, the key is to establish feeds and all the time maintain saturations of between 75 to 85% to prevent excessive pulmonary blood flow and steal from the systemic circulation. However, the circulation remains fragile, and home saturation monitoring and parental education is vital to achieve good outcomes. So what's the alternative? If the classical Norwood as described by William Norwood had the BT shunt and the problems of shunt physiology, so low diastolic pressure and potential for coronary steal and potential for cardiac arrest, what are the other options? Well, a Japanese surgeon called Sunji Shano invented the Sano shunt. So this is a conduit between the right ventricle and the pulmonary artery to supply blood to the lungs. So what are the advantages to this? Well, it excludes the possibility of shunt physiology, so avoiding the lower diastolic pressure and the coronary steal. But to do this operation, one needs to make a ventriculotomy, and that can result potentially in poorer right ventricular function, can act as an arrhythmogenic focus in the future, can lead to aneurysm formation in the future, and potentially can lead to impaired growth of the pulmonary arteries. So those are the two alternatives in dealing with hypoplastic left heart syndrome. Which one do we choose? Well, it has been the subject of probably the only a large randomized controlled trial in pediatric cardiac surgery known as the single ventricle reconstruction trial. And the first publication was in 2010 or 11 in the New England Journal. And essentially, it detailed 555 patients randomized between the classical Nord and the modified or right ventricular to PA conjugate Norwood across 15 North American centers. And the initial findings at 1 year were that there were more deaths or transplants in the classical group, but there were more unintended interventions in the RV to PA conjugate group at 1 year. So survival was better, but at the expense of more interventions in the RV to PA conjugate group. However, with ongoing follow-up by 6 years, there is no significant survival advantage in the RV to PA conjugate group. So, with no clear advantage of one technique over the other, it seems to be that a tailored approach to each patient, taking into account surgical preference and familiarity, will likely lead to the best outcomes. A further alternative is the hybrid approach, developed just as an alternative to a Norwood, which is difficult and high-risk surgery. The principles are the same: to create a common atrium, this time by an atrial septostomy. Okay, so similarly to a Rashkind in a transposition, so a balloon atrial septostomy, ductal patency is maintained either with a long-term prostaglandin infusion or by ductal stenting. And then the only real surgical component of it is to place bands on the branch pulmonary arteries and therefore restrict pulmonary blood flow. Seemingly attractive, it is quicker, simpler surgery. It avoids cardiopulmonary bypass in a potentially sick neonate and avoids high-risk surgery. However, getting the pulmonary artery bands right and achieving a good result is difficult, and it also then makes the second operation, which is an arch reconstruction, cavopulmonary shunt, and Damus K. Stanton anastomosis to connect the right ventricle to the reconstructed arch is a much more difficult second operation. It has therefore become an unpopular option in most centers, but the principle of using bilateral pulmonary artery bands to temporize a sick child, followed by an interval Norwood at 3 to 4 weeks, is widely used. So I think I've been talking for just over half an hour now, so I'll stop there, and I'll take any questions on the chat, but I'm sure that Ms. Van Doorn is ready to talk.
Okay, good afternoon, everyone. And my name is Karen van Dooyen, and I am one of the congenital cardiac surgeons at the Leeds Teaching Hospitals in the UK. Shafi just told you about the operations for neonates, and I thought I'll just take you out of the operating theater for a little while and talk about in some more detail about how actually we care for the patient, not just for the heart, but across the whole patient pathway. So as cardiac surgeons, we're very familiar with looking at the heart, and here's an image of a tetralogy of Fallot. This patient, or in our view, this heart, goes to the operating theater, and then we repair the heart. But that is only half the story, because ultimately the pathway starts here with this blue baby, and then a lot needs to happen before we ultimately end up with the healthy child. So particularly in congenital cardiac surgery, the patient pathway is very, very complex. And we also have to recognize that there are a very large number of different cardiac pathologies. And as Shafi already sort of illustrated in his talk, there is a very wide variety of operations, but also a very wide variety of setting an indication for surgery, the timing of the surgery, the way how the patient is managed in the operating theater and also after the operation. So I've split it down in preoperative, intraoperative, and postoperative. And in the rest of my talk, I just sort of illustrate how we approach that in the UK setting. And I'm very much aware that sort of every country has their own health system and the way things are organized, but I think the basic principles of the management of the patients actually do apply. The other really important thing about congenital cardiac surgery is actually we treat patients across the age range. So we can start off with a neonate. And with that neonate comes particular neonatal pathophysiology and also issues with regards to the size of the child. And then we move all the way across to old age, where patients may not only have congenital heart disease, but they may also have acquired heart disease and other age-related pathology. So again, this further complicates the management of our patients. And where do we stand as the cardiac surgeon? Actually, we very much feel at home in the operating theater, and that is actually where most of our education is. And most cardiac surgeons, including myself, actually do not have any formal intensive care qualifications, any formal pediatric qualifications, but our patients actually need an awful lot of those skills. So how do we get about that? So how can we complement our knowledge and our skills so we can make valuable contributions to ultimately receive the excellence of care that we need to provide? So in the preoperative period, the Joint Cardiac Conference, or in some units it is called an MDT, multidisciplinary meeting, is really, really important. So there is a weekly meeting quite often, or sometimes twice weekly meeting, where cardiac surgeons and cardiologists and quite often other specialists meet. And during that meeting, patients are presented with their history and their pathology, and the preoperative imaging is reviewed. And it is really important to see the pictures, and it is even more important to see those images together with the imaging consultants, because a lot of the imaging is now so advanced, and also the software and display that is needed is again so advanced that you will not be able to get the finesses and the detail out of that if it is just you sitting behind your laptop. The other important thing is that because both are present, you and the imaging consultant, you can ask them to show you what is important for you for your operative repair or for your intraoperative decision making. So if say an MRI is done for a cardiologist who has requested it, and it shows a VSD and it says the shunt is 2:1, well, that is okay. But as the surgeon, you really want to know, where is this VSD? Is it in the apical aspect of the septum? If it is inlet, is it below the aortic valve? And by the way, are there 1 or 2 or 3 VSDs? So these things are important. Say for redo operations, you also really want to know the relationship between the sternum and the underlying heart, and whether or not the aorta is adherent to the sternum. So having a conversation with the imaging consultant actually allows you to ask the questions that you would like to ask, and also allows them to give you additional detail that you would not be able to pick up yourself. And then obviously the other thing you need from that meeting is the hemodynamics and electrophysiology in selected patients and so on. So this JCC conference will then come to a decision for that particular patient, which is a joint decision, which may be that you either operate on the patient, or the patient goes for a catheter intervention, or occasionally actually that surgical or interventional treatment is not needed at the moment. The other thing that the JCC will decide is the timing of the surgery. So does this patient go on the waiting list, or is this a neonate with a transposition of the great arteries who is in-house, was born yesterday, and therefore needs an operation this week? It's really important to record that JCC decision, and that decision goes in the patient file and travels with the patient. Because you probably see 10, 20, 30 patients at the JCC. So by the time you come to operate on that child, you really have forgotten everything that was already said. So record the JCC decision and put it in a place where you can find it again when the patient is being operated. Sometimes actually decisions change. So sometimes something changes in a child, or it may be that you review the case and you've had a really intense discussion last time, and say for a Norwood you decided, oh, I think we go and do a BT shunt here, but then some more information becomes available, and then you think, okay, we better do a Sano shunt. So it is not written in stone, the decision, but it is a really strong guidance and help for you to know where to go. So moving on from the preoperative phase, we now move into the operating theater, and that is where most of us actually really feel very at home. But what we need to know in that operating environment to be able to do the best possible job we can for the patient? Well, obviously we need to make sure that first of all we're booking the right operation and the right site of the incision, and the World Health Organization checklist for safer surgery actually now forces us, quite rightly, to really stand still, take stock and say, okay, just forget about everything else. I'm here to do an operation. What is it that I'm going to do for this patient today? Do I have the right patient in the operating room for the right procedure? And am I operating on the correct site? The other thing you need to discuss before you start the operation is how am I going to run my perfusion? What cannulas am I going to use? I'm going to use cardioplegia. What temperature will I be doing my operation at? And again, these things are important. If you always work with the same set team and people know your habits, then obviously you can do with less communication. But if you actually work in a large department and everything may be a little bit different, or you're the new person coming in, it's really important to spell those things out. It's also important to talk to the anesthetist and find out what the inotropes is. But the inotropes are that you may want to use. Are you going to be experiencing any pulmonary hypertensive crisis? Are there any particular antibiotic requirements? And then the other thing is, finally, before you scrub up, you really want to see the preoperative imaging again. Refresh your mind, because you've just been operating on another patient or you've been on the ICU, and you really need to know exactly what the case is about, where, because you're going to go in for a really targeted approach. In most patients now, we would do an entry and an exit TUE, and the entry TUE, the transesophageal echo, is really that when the patient has been anesthetized, okay, what is the function, the latest update on the function? And actually, the patient may have had an echo maybe 3 or 4 months back, now it's come from your waiting list and is in the operating room. Just check that nothing has changed. But then most importantly, you do need your exit transesophageal echo. You want to know what the function is after you've done the repair, but most importantly, you want to know that your repair is as good as you can possibly get it. And you need someone who has really good echo skills to do that for you. It's no use someone just having a quick look and saying, oh, I think it looks okay. Or looking at the mitral valve repair and say, well, I think there is only a little bit of a leak. But then if they go systematically and they look at all the areas of the valve, then actually there is quite an important leak. So you need someone who is going to be honest, objective, and frank. And obviously you're the surgeon there, you think you've done the best job you can do. And then, damn, there is a bit of a leak on the VSD patch. Yeah, so you don't want to hear this, and it does hurt your pride. But in the end, this patient needs the best repair. And the important thing is that if you know now that there is a leak, you can still picture in your mind what that defect looked like. You probably know there was a muscle bundle there and you should have taken your stitch a little bit deeper. So cardioplegia is much safer nowadays. So the best thing is, if it is a hemodynamically significant defect, and if you think that actually you can do better on this, you go back on bypass, you cardioplegia again, and you repair that residual leak. So you then have a further echo, and then you quite often find that actually this patient is performing a lot better. So the bottom line is that the patient should leave the operating room with the best possible repair. However, sometimes it may be that you've repaired the mitral valve and you try to absolutely do the best for that valve, but it is really a difficult valve. And you have no other options unless you're going to replace that valve. Then obviously it may well be that the decision then is, well, you have either a little bit of residual stenosis or maybe still a mild leak. And so, well, actually, this is the best I can do, and I don't really think it is worth replacing that valve. So then clearly that patient will leave the operating room with a residual defect. And then clearly that patient needs to be watched very, very carefully in the postoperative period to make absolutely sure that that defect is tolerated and that the initially mild regurgitation is not going to progress to severe regurgitation by the time the patient is ready for discharge. So then moving on to the postoperative phase. Yes, this patient has come out of the operating theater, yeah, but this patient is still partly under your care. So daily post-operative multidisciplinary ward rounds are really important. Ideally, first thing in the morning with the intensivist, the surgeon, and the cardiologist. And every discipline will add to the discussion and to the expertise in the management of the patient. It's not unusual to have a difference of opinion. It's actually very healthy to have a difference of opinion, as long as you are open-minded and you can have a discussion. And sometimes it is also necessary that there is, if people can't agree, that there is an agreement whose sort of advice will be followed. But generally, particularly if patients have no residual defects, patients generally progress. It's also important to recognize that most intensive care units have sort of a preference for drugs. So they have a particular drug that they use for to get the blood pressure up, and another drug that brings the blood pressure down. And every drug has side effects. But as long as you know the drug that you prefer, as long as you know that very well and you are very aware of its side effects, then actually it doesn't really matter which upper and which downer you use. And the other important thing about the intensive care is that you're aware of the age of the patient that is being treated. And particularly for neonates, there is age-specific physiology. These patients may still have an elevated pulmonary vascular resistance. These patients, quite often in the first few days of life, when they have surgery, they become quite edematous. Whilst on the other hand, if you do adult congenital heart disease and you happen to operate on an old patient, then these patients may actually be quite frail, or they may have been smokers. So all these things are important to take into account. The size of the patient is also important. And most of the time, if you have your equipment and your disposables, then you can perfectly use that in pediatric patients, probably going down to about 20 kilos. But then when patients become smaller, you really need size reduction in the equipment that you use. And if for an adult you take a blood sample and you use 10 mils of blood, then clearly if you have a neonate, you cannot use those same blood tubes, because the patient will actually be exsanguinated by the time you have done all your tests. So in very small babies, you're going to need specialized equipment, and you're going to be needing to be very, very delicate. And also babies move all the time. Every drip or drain you put in absolutely has to be very, very well fixed. You need your specialist nursing care. And again, these nurses, if they're specialist nurses, they actually will know a lot about these patients, and they will be able to give you information about how that patient is behaving that you cannot find on the observation charts or other sort of ways we are monitoring the patient. If a patient on the intensive care is not progressing, then it is really important to reinvestigate the patient. And since we're talking about early post-operative patients, it is really important to do some further imaging. So the easiest thing to do is to do a repeat echo, which is a bedside test. And inexperienced hands can give you a lot of information. However, if that patient is still not progressing and you can't get this patient off the ventilator, or the patient is cyanosed, whilst you expect to have a pink patient, or the blood pressure is persistently low, then you will need to reinvestigate the patient. Because the most common cause of post-operative congenital patients not progressing on the ICU is that the repair is not good enough for that patient at that moment in time. It may absolutely not be your fault, or maybe it is. maybe stitch is cut out, maybe a collateral has opened up, maybe the mitral valve, which looks really good initially, has now fallen apart. But unless you are able to identify where the problem is, that patient will not progress. So there has to be a common acknowledgement and a common way of working that when patients don't progress, the team gets together, you look at all the observations, you examine the patient, and you make a plan for further investigation. But the patients that are progressing, and most patients will, they will then be transferred to the ward, mobilized, and then you're talking about discharge. You can't send the patient just out in the community. You have to educate these patients and you have to educate the family. A number of patients with congenital heart defects will have residual defects or will need further treatment. A patient will need to know about the medication. The patient will need a pre-discharge echo, so that is a baseline for when they come back in the clinic in due course. And most patients will need an outpatient follow-up anytime between 2 and 6 weeks, depending on the type of surgery they've had. Also increasingly, we are asking ourselves, do patients need to stay in hospital for a long time? Because in the past, we actually were quite worried about these patients and they stayed in hospital for a week or for 2 weeks. Nowadays, we're actually more confident and we're going to say, well, hospitals are actually places where there is a lot of infection and actually our hospitals are overcrowded. So can this patient be discharged either to home if they live locally, or can they go to a patient hotel and then come back for an early outpatient clinic? And if the patient has a worry, then in the meantime, they can ring a specialist nurse. And whilst in the past, patients that say needed anticoagulation and needed a target INR of 2 or 3, and it was only 1, we kept these patients in hospital. Nowadays, we put these patients on subcutaneous heparin, and then they come back daily for the blood test and for their injections. So it is really important to continuously drive forward the outcomes. And as part of that process, we do clinical audit. And obviously you're all familiar with that. So you plan an audit, you measure your performance, you make your improvements, and then importantly, you maintain your improvements. And by doing all these things, you complete your audit cycle and you drive quality forward. So in the UK, what type of outcome measurements are we using? And the answer is we're using an enormous number of them, but we do have a national cardiac audit which produces every year a big report, but it comes out once a year. This is the report that came out in 17-18, but actually the one for 18-19 has since also come out, and it shows that the 30-day mortality across the board, taking into account all congenital cardiac operations in the country, is 1.4%, which is actually incredibly low. Whether or not we're going to have the same this year with the audit coming out, because of all the COVID problems, I think the mortality will have gone up a little bit. The other way we measure outcome is by using blood curves. And the principles of that outcome measurement is based that there is a risk model that has been designed and that is based on an historical population of UK patients. And for every operation you do, you can calculate the risk of that patient surviving the operation. So if all your patients that you operate on, say in a month, survive their operation as expected, then your performance is